The scholars participated in projects at a variety of community health centers throughout the United States. And according to the National Association of Community Health Centers, these centers serve over 22 million patients annually at over 9,000 locations throughout the United States. And these centers focus on affordable access to health care and decreasing health disparities. The scholars' projects included an evaluation of no-show rates and the use of technology, culturally competent care of the deaf and hard of hearing, childhood obesity, electronic health records and patient cycle time, health literacy, healthcare reform, and provider-patient communication in pregnancy and the prenatal state. These scholars chose projects that would serve these community health centers and allow these centers to look at an aspect of the care that they provide from the patient experience.
My name is Jerry Abraham, and I'm a GE NMF Primary Care Leadership Program Scholar from the University of Texas School of Medicine in San Antonio. I worked at the Franklin Primary Health Center in Mobile, Alabama. My research focused on the National Center for Quality Patient-Centered Medical Home Model Recognition process and the challenges federally qualified health centers face when applying for this designation. The objective of this research project was to assess the preparedness of the Franklin Primary Health Center for NCQA patient-centered medical home recognition, particularly Level 3. The methods of this research project was to identify components that require additional improvement for the NCQA PCMH application, analyze federally qualified health center performance data, design and test an intervention to improve improvement variables such as no-show rates, patient wait times, and patient satisfaction. Key findings of my research project include the areas for improvement identified included assessing patient management goals, improving utilization of electronic health record data, improving health literacy, improving patient satisfaction, improving scheduling protocol, and improving workflow patterns. Additionally, other areas for improvement include reducing patient wait times, reducing patient no-show rates, and increasing provider productivity. The analysis showed that 60% of patients at Franklin Primary Health Centers across their 24 clinics had a 60% attendance rate on average. 10% canceled, and 30% of patients did not show for appointments. Additionally, patient satisfaction survey data showed that 45% of Franklin Primary Health Center patients were highly satisfied with the care they received, with over 75% of patients showing that they demonstrated some form of satisfaction from the Franklin Primary Health Center. Only 4% of patients were poorly satisfied. Recommendations from this study include personal telephone call reminders to patients help reduce patient absenteeism. Reducing patient wait times is the most important variable in improving patient satisfaction. Furthermore, continued capital investments in health information technology will continue to be the best investment with the greatest return for community health centers. Additionally, forging partnerships and affiliations with academic medical centers, hospital systems, and large specialty groups increase the fluidity of the care continuum and the total number of providers patients have access to. This is the most important, significant predictor for whether or not a practice can achieve NCQA patient-centered medical home recognition. In conclusion, 75% of federally qualified health centers have achieved NCQA patient-centered medical home Level 3 recognition. Therefore, it is imperative that the Franklin Primary Health Center diligently work to obtain the same designation in order to competitively compete for various incentives, financial and other resources that will be available to community health centers in the future as healthcare reform continues to unroll. This will empower the Franklin Primary Health Center to do more to improve the health of their patients and the community that they serve in Mobile, Alabama. Thank you.
Hello, my name is Anna Herring. I'm a fourth-year medical student at the University of Texas School of Medicine in San Antonio, Texas. I was placed at Centro Med in San Antonio. My project was titled An Effort to Increase Enrollment in Cancer Screening Procedures. By working at Centro Med, I learned that there are grants available to help an unlimited number of uninsured and underinsured patients receive cancer screenings. However, many patients are not getting referred for the procedures in the time frame that is recommended. My objective became to increase preventive care utilization among Centro Med patients with the focus on mammograms, colonoscopies, and pap smears. I accomplished this by working with my site mentor and a site nursing leader to create a pre-clinic form that can be filled out by triage nurses during walk-in clinics. This form shows when each of the procedures were last done, the results, and the recommended screening interval. This will help notify the provider that the patient is due for their next cancer screening procedure. It will also give the provider a chance to discuss the previous results with the patient if they had not been informed already. This form will then be sent to a care coordinator at the end of the day so that the patient can be called to schedule their appointment for the specific procedures. There are no key findings since it will take a year before we can see noticeable results. I would recommend that Centro Med figure out the percentage of patients that currently meet national screening guidelines and compare this with the number of patients that meet the guidelines in a year to prove that this process is efficacious. Overall, I enjoyed working on this project because it showed how something as simple as a form and a phone call can make a big impact on a patient's health. It also showed how important it is to have optimal communication between all employees of a community health center.
Hi everyone, my name is Mary Cothey and I'm currently a second-year medical student at the Commonwealth Medical College located in Scranton, Pennsylvania. This past summer I had the pleasure of working with Adelante Healthcare in Phoenix, Arizona. My project, Raising Decibels, was all about engaging the deaf and hard of hearing community at Adelante Healthcare. I was initially presented with a document from the State of Arizona Office of the Attorney General Civil Rights Division and asked if I could assist. A deaf patient of Adelante Healthcare had filed a formal complaint with the Attorney General, which had been settled in mediation. The objectives of my project was to ensure Adelante Healthcare was in full compliance with the points of the mediation agreement and to improve Adelante Healthcare services and support to the deaf and hard of hearing community at all levels of patient contact. The project was completed in stages over a period of 7 weeks with support from Sean Furman, a deaf specialist at the Arizona Commission for the Deaf and Hard of Hearing, and Marianne Stefko, the assistant principal of the Scranton School for the Deaf and Hard of Hearing Children in Scranton, Pennsylvania, as well as discussions with Adelante Healthcare site leaders, administrators, and call center representatives regarding the management of the deaf and hard of hearing patients. During this period, I coordinated 2 two-hour healthcare provider curriculum trainings, a deaf and hard of hearing sensitivity training provided by Sean Furman for all Adelante employees. I compiled a list of American Sign Language course offered in the greater Phoenix area, and I contracted an additional American Sign Language agency to provide American Sign Language services to Adelante patients. I created a protocol for the management of deaf and hard of hearing patients, and I collaborated with information technology to identify and track hard of hearing patients in Adelante Healthcare's electronic health record system. Over this period, I discovered there was a general lack of knowledge regarding scheduling and confirming an American Sign Language interpreter at Adelante Healthcare. In addition, physicians and medical assistants were unaware of a way to identify and track a deaf or hard of hearing person in the electronic health record system. In the future, Adelante Healthcare should hold yearly training sessions on working with interpreters. And Adelante must identify all of their deaf and hard of hearing patients in the electronic health records, as well as document each patient's preferred method of communication. After a formal complaint was filed against Adelante Healthcare, the organization was determined to improve its support and services to the deaf and hard of hearing community. I had the privilege of helping Adelante Healthcare make organizational changes that promote effective communication and patient-centered medicine. Thank you for your time.
Good afternoon, everyone. My name is Michelle Lagua, and I am currently a graduate of the USC Tech School of Medicine Primary Care Physician Assistant Program. As a General Electric National Medical Fellowship Primary Care Leadership Program Scholar, I was assigned to AltaMed in East Los Angeles for my externship. There, I worked with Vilma Andari, the Director of Obesity Management Programs. We evaluated the effect of their new childhood obesity program at the clinic in Boyle Heights. Solutions and Treatment in Obesity Management and Prevention, lovingly known as STOMP, was designed to emphasize the importance of parent participation in a childhood obesity treatment plan. This program was modeled after the original childhood obesity program pilot that AltaMed had implemented in Santa Ana. The difference between this particular program and the one in Santa Ana is that parent information and biologistics were tracked alongside their child. Body mass index, or BMI, was tracked and analyzed for both patients and their parents during a 12-week educational and exercise intervention. Measurements were taken at the initial enrollment of both child and parent, again at the 6-week midpoint, and then finally at the 12-week conclusion of the program. Parents underwent patient education on diet and healthy lifestyle choices, while children participated in weekly exercise sessions. Sessions were provided in both English and Spanish to ensure complete understanding of the intervention. Moreover, both parents and children signed a contract to complete certain homework assignments and commitments as well. This included daily exercise programs, restriction of time in front of the television, limitation of meals outside of the home, elimination of caloric drinks, and a commitment to lose a certain amount of weight by the end of the intervention. Along with these commitments, families were required to attend all information or educational sessions. Families were disenrolled if more than one session was missed during the intervention. The participants ranged anywhere from 6 years of age to adolescence. A total of 24 families were originally enrolled in the program at the beginning of May. 7 families were disenrolled from the intervention due to attendance. Of the remaining 17 families, 6 children were monitored from the 6 to 8 year age group, 8 children from the 9 to 12 year age group, and 3 children from the 13 plus year age group. At the 6-week midpoint check-in, there were significant changes in body mass index, found both in children and their parents. More importantly, there seemed to be a direct correlation between the change in a child's BMI with their parents' BMI. This validated the importance of seeking parent participation when designing and implementing a childhood obesity intervention. Recommendations were to make parents more accountable for not only child but entire family participation in an obesity management and prevention program. Surveys should be distributed to determine the parents' attitudes towards and perceptions of the program in question. It would be wise to evaluate any perceived barriers to effective intervention as well. Participation from parents is a key determinant in the effectiveness of any childhood obesity management program. Future programs designed and implemented by AltaMed will monitor both parents and their children's biologistics throughout the intervention as a result of this study. Thank you guys for your time, and if you have any questions, feel free to email me at Michelle, Michelle .lagua, Lagua, @gmail.com. Thank you again.
My name is Vanessa Lewis, and I am currently a second-year osteopathic medical student at the Philadelphia College of Osteopathic Medicine, Georgia campus. This summer, I was placed in Nashville, Tennessee at the Matthew Walker Comprehensive Health Center. I began this project with my own personal interest in women's health in underserved areas. Upon arriving in Nashville, I discovered that this area was an area with a high rate of infant mortality and low birth weights. This made me think of the type of provider-patient communication that should be had to ensure patient awareness and expectant mothers of these communities. My project at the site was focused on creating a document containing the standard of care procedures for the obstetrics department. There was a need for a physical manual with the administrative and clinical information on hand for providers and other related staff to use as for reference. Initially, a needs assessment was performed by evaluating the electronic medical record system that's currently in use. Then I conducted interviews with the providers to discuss their patient counseling experiences. This information would help shape the educational topics to be included within the manual. After referencing the Guidelines for Perinatal Care book by the American Academy of Pediatrics and the American Congress of Obstetricians and Gynecologists, I had a meeting with the medical director, and a final manual was adapted to fit Matthew Walker's needs. Through this manual, I was able to create something that was consistent with Matthew Walker's mission of providing comprehensive health care to the women that they serve from preconceptive to postpartum care. The manual was organized by term with the pertinent services that they should be receiving. For example, preconceptive care for a woman who is trying to get pregnant was designed to ensure optimal maternal health prior to conception. Related services would include a physical exam, blood work, dental care, nutritional advisement, and a behavioral health assessment. Also, for prenatal health, the appropriate labs and screening tests for the expectant mother are listed at their appropriate time throughout the various trimesters. In addition, routine behavioral health and dental evaluations are listed, as well as trimester-specific topics that the physician should be discussing with their patient during visits. As recommended, a digital copy should be kept so that the administration can modify and update this document as needed. Moreover, I would also like to recommend that this manual serve as a template for other departments to follow in order to create a similar manual for the services that they provide. As I reflect on my time in Nashville, I recognize what a rewarding experience this was. Everyone at the Matthew Walker site was so nice and so helpful to me. Dr. Williams was especially instrumental in guiding me throughout the stages of my project. Not only was the opportunity to serve and gain clinical experiences in the community health setting valuable to my medical education, but it also strengthened my desire to pursue a career in primary care. So I am very, very grateful to have been chosen to participate in this program. Thank you again for the opportunity.
Hello everyone, my name is Daryl Nowaki. I am a second year physician assistant student from Chatham University in Pittsburgh, Pennsylvania. For the PCLP, my placement was in San Antonio, Texas at Central Med. During my time there, in conversation with the clinical director, I decided to work on and evaluate their no-show rates. Central Med was running at a 30% no-show rate when I arrived, right around there, and obviously this is seen as a problem since the national no-show rate is around 5%. So the objectives that I was looking to do is to find ways to improve this no-show rate through awareness of the problem, examining why patients don't come, looking at the appointment reminders, and take a look at improving wait times and patient flow. In order to do this, I looked at online research at what other clinics have done. I looked at what Central Med is currently doing and analyzed cost versus possible benefit of implementing these changes. Now, looking at what other clinics have done, I went online and did research through journals and saw what articles were published referring to improvement of no-show rates, as well as some websites that were dedicated to different strategies to improve no-show rates. In this time, there are many suggestions that included different appointment reminders, charging fees for missed appointments, dismissing chronic offenders, as well as looking at the flow studies throughout the clinics or the offices to improve patient wait times and really give a better customer service satisfaction feel with each appointment. When patients are looking at when they come to the clinic, they really need to know why they are returning to the clinic, and making sure that this education is given to them so that they know the importance of showing up for their additional appointments. Also, the clinics or offices with the best no-show rates carried out several strategies of appointment reminders, including mailers, phone calls, and if they did miss, follow-up phone calls to find out why they missed their appointments. Additionally, if patients spend less time in the waiting room and are seen quicker, they know that there's a set amount of time that they will spend at their doctor's appointment and don't have to miss a half a day or even a full day of work or school. So the recommendations that I'm making to Central Med are, first off, to change their automated calling to the evening. Right now they work on an automated calling that starts at 8 a.m. and usually lasts until around 1 p.m. before all their calls are made. During this phone call, it goes out through an algorithm that the computer detects whether the phone call is answered or whether it goes to voicemail. If it's answered, the patient has a selection to choose in English or Spanish, their reminder. But if it goes and is detected that it picks up a voicemail, then it goes through their time, date, and location of their appointment in English and then in Spanish. And with Central Med being in San Antonio and having a large Spanish-speaking population, it is important to have the Spanish done up front. So this was another recommendation, that they could actually pre-select the language when the patient makes the appointment or sets up the appointment, so that whatever reminder they decide to use, whether it be voicemail or calling, email, texting, that it goes out in the preferred language of the patient. Also, it's an advantage of the automated system that they can have the calls go out whenever they want, so they have the opportunity to make them in the evening without needing to use resources such as personnel to make the phone calls. And when they go out in the evening, they're more likely to find patients at home between 4 and 9 p.m. Adding a postcard reminder was another recommendation, as patients can change their number, text with the changing of track phones, or don't always check their voicemails, where not many people change their address, and adding a postcard reminder seemed fiscally reasonable as well. In identifying why patients miss their appointments, this would add some onus to the practitioner to make that phone call afterwards and say, hey, why did you miss the appointment, and try to either, that gives an opportunity to reschedule an appointment or to find out the condition of the patient. Also, just improving customer service. As the change in healthcare comes, patients are going to have more options, and you need to be customer friendly, door to door, to attract those patients and keep your patients. And additionally, like I talked about before, decreasing the wait times through flow studies could also help. Overall, my time at Central Med was great. I really appreciated the clinical experience as well as the leadership activities, and I really would like to thank the GE and MF and the scholarship program that made this possible for me to have this great opportunity.
Thank you for taking the time to listen to and review my executive slide from my experience as a PCLP scholar in the summer of 2013. My name is Stephanie Oji, and I am a second-year medical student at Morehouse School of Medicine. During this past summer, I was able to spend my 6 weeks at United Neighborhood Health Services in Nashville, Tennessee. During my time there, I implemented a project in hopes of improving the health literacy of the patients in United Neighborhood Health Services. That leads to my title of my project, Increasing Health Literacy Among Patients, the United Neighborhood Health Services Resource Book. The reason why I find health literacy important is studies show that a lot of the diseases that are prevalent within the United Neighborhood Health Care community, which are diabetes and hypertension, are correlated with health literacy. And let me define health literacy as a degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. Now, studies show that limited health literacy skills are associated with chronic diseases such as diabetes and hypertension, as well as poor maintenance of these diseases. So therefore, with the high diabetic population that is seen at United Neighborhood Health Services, increasing the health literacy of their patients could actually increase their management of these diseases and the overall health of the population. That is why I was interested in completing this resource book for this particular community. So when I got there and received the okay, I decided to, come up with an objective to spearhead the project, which is listed here on my slide, just to increase the health literacy amongst the patients by creating a resource book that would be used during the patient and clinician or patient-employee interaction at the center. The book started off as a resource to be used within the diabetic population specifically, but it later ended up being to include all patients, not just people with diabetic needs. In order to get this book done during this small period of time that I had within the community, I had to attend several meetings between the site leaders as well as my mentor at Meharry and Vanderbilt Alliance. At these meetings, I received feedback pertaining to the gathering and the organization of the information and organizing the book in a way that would be most accessible to both the clinicians as well as the other employees at the centers. And I also took the opportunity in the time within the community to collect information about the different topics that would be included in the resource book, including general cost assistance. That was more specific to the insurance plans within the area that are offered to people at low income who receive low income, as well as dental services and food banks and things of that nature, which can improve the health literacy of the patients. And these are all targeted, or these all are specific towards people who have limited income. So after completing these meetings as well as gathering this information, I was able to compile a resource book which included 33 affordable resources within the Nashville area, as well as information of the Affordable Care Act. With the marketplace opening in October, I believe that information was necessary to be included in that book. And that book was actually placed at all of the United Neighborhood Health Services within the community. Those are 9 of the clinics within Nashville have a copy of that book to be used by the clinicians and the other workers within the clinic. And recommendations for the future, I would hope to just continue to update the book because numbers change as well as addresses, as well like that. So it will be important to have that book continuously updated so that it can still be beneficial to the patients. Also, in the future, I would like to make it adaptable in a brochure that can be taken by the patients. During this time, I learned a lot about working in community health. I learned a lot about working in community health centers, and it really did push me to be more involved in the community. I saw that there is a great need for organization because there were a lot of resources within the community that were available. However, there was not a single place you could go to collect all of the information within the community. So that's why I was very glad that I was able to implement this book in the short time that I had. I thoroughly enjoyed my time in Nashville, and I thoroughly enjoyed the opportunity that was given to me by PCLP, and I really look forward to just meeting more PCLP scholars as well as networking within this tight community, and hopefully visiting Nashville in the future next summer to complete as well as build upon this project. Thank you so much for your time.
Hello everyone, my name is Tem Waldesus. I am a second year medical student at the University of California, San Francisco School of Medicine. I was fortunate enough to be placed at West Memphis, Arkansas at the East Arkansas Family Health Center. So my site was very enthusiastic with having us get the most out of our PCLP experience. The senior leadership were very open and let us PCLP scholars into all of their administrative meetings. After attending their monthly continuous quality improvement meetings, I observed that the EMR system that they had recently implemented was not being used to its fullest capacity in the evaluations of clinical operations, and the variables tracked in their EMR had the potential to be expanded upon in evaluating provider performance. I also observed that the patient cycle times were not being evaluated monthly, despite patient satisfaction surveys suggesting cycle times were prolonged. So, given that, I tweaked my previous proposal on no-show rates and really wanted to develop a model for analyzing patient cycle times at East Arkansas Family Health Center using data tracked by their EMR to evaluate provider and clinic efficiency. So I, en route of developing that project, I had to generate the EMR data. So they had a solutions tool attached to their program called Bridge IT, and I had to set a date range to pull all of the patient encounters, and I set the date range from December 1st, 2012 to July 1st, 2013, and that generated 44,000 data points. A lot of these data points were incompatible, meaning they had cycle times that were shorter than 8 minutes, missing patient arrival and departure times, and some had missing provider labels, like which provider the patient was seeing. So after adjusting and filtering those points, it got me to a total of 4,497 data points. And then I organized the data by provider, date, site, and then I analyzed it by calculating the cycle time, which was the time when patient arrived in the clinic to when they walked out of the clinic. So I calculated that, and I also did cycle time encounter groupings. And I also calculated the duration from their appointment time to when they left the clinic. I then filtered the tardy encounters and then repeated the analysis I did in the previous step. So I calculated the cycle time averages for all of the providers at each of the 5 sites, and then I grouped the cycle times based on their duration. So whether I counted the amount of encounters that were within 0 to 30 minutes, 30 to 60 minutes, etc., etc. And then I plotted and represented the data. And so what I found was that the cycle time goal published by other CHCs and the literature of family management, East Arkansas Family Health Center has not met the goal on 79% of the encounters. And the common cycle time goal was 60 minutes per encounter. So East Arkansas Family Health Center had an average cycle time of 99 minutes, with significant variances across all their sites. And outstanding encounters were defined as encounters with cycle times above 2 hours. So they had 1,295 patient encounters over the course of 8 months that were longer than 2 hours. And I also figured out that the variables that are generated by Bridge IT and are tracked by their EMR system can serve as a great tool to evaluate their clinical operations. So for my recommendations, the EMR check-in and check-out times that I use to calculate the cycle times that are recorded by the front desk administration should probably be enforced. Just so that there's higher confidence in the values, and that each provider be matched with the nurse so that this team can examine their cycle times and manage their own bottlenecks. So it kind of would narrow in the focus of the obstacles in having a very short or brief cycle time. I'd also recommend using monthly performance dashboards and efficiency evaluations with continuous goals and aim setting, just so that people, so that providers, after knowing their benchmarks, have a plan and a goal for the next month that they can strive for in order to be continuous improvement in their cycle times. So that was a sum up of the project that I did over the summer. And I have to say that my PCLP experience was easily one of the best experiences that I've had as a medical student, or even a student for that matter. And I was extremely interested in the mission of the PCLP program when applying for it 8 months ago, and felt that the experience that I received was well above what I can even imagine. So I'm very grateful for the staff and some of the fellow scholars that were with me at the site. So thank you for listening. And if you have any questions, please do email me. Thank you.
In terms of each project, I'm going to cover each one with a brief synopsis to give you some background information about the amazing work that the scholars were doing in their very short time frame at each site. The first project, titled Obamacare Healthcare Reform Across the Nation, was completed by Dr. Adetayo Lawal, who is a medical student at Morehouse School of Medicine in Atlanta, Georgia. He conducted his project with Ultimed in Los Angeles, California. His project focused on Ultimed's preparedness for healthcare reform, and he utilized branding, marketing, and communication departments in his efforts to develop a strategy to reach the providers and patients of the safety net organization. The presentation was developed to describe the changes in healthcare and the effects on Ultimed's services. Pre- and post surveys were developed to assess the provider's knowledge base on this topic, and the presentation was ultimately delivered to the Ultimed Research Committee. The project will culminate in the presentation with surveys being delivered to the providers during a fall provider meeting. The second project was titled Increasing Health Literacy Among Patients, a UNHS resource book. Student Dr. Stephanie Oji is a medical student also at Morehouse School of Medicine, and her project was completed at the United Neighborhood Health Services, UNHS, in Tennessee. The project consisted of support related to health literacy and the self-care of diabetes. The diabetes management team worked to develop a resource book for patients that included concepts of affordable fitness and healthcare options, food banks and farmer markets, and information related to the services at UNHS. Subsequent reviews of the book brought insight into an expansion that could meet the needs of all patients, including topics on social fitness, retinopathy screening, and information about the Affordable Care Act. The final resource included 34 different areas for patient use and was broken into 6 categories, including general cost assistance, healthcare facilities, dental services, food banks, physical and social fitness, and mental health support. This resource is now available electronically through the UNHS website. The next project was titled Monitoring Patient Cycle Time, utilizing electronic medical record data to assess patient flow and provider efficiency. Student Dr. Tem Voldiesus is a medical student from the University of California, San Francisco Medical School, who completed a project at the East Arkansas Family Health Center in Crittenden, Mississippi, and West Memphis, Arkansas. The scholar focused on EMR use at these sites and began the project with observing a continuous quality improvement meeting. The scholar identified an issue related to patient cycle times, which were not being evaluated monthly, despite patient surveys that suggested these times were prolonged. According to the literature, cycle times are a significant indicator of clinical efficiency and capacity, and the duration of time a patient spends in the office has been directly linked to patient satisfaction, and monitoring these cycle times can provide insight into bottlenecks in the normal patient appointment process. The scholar was able to access data related to 44,010 patient encounters, and through that review determined that roughly 4,500 visits had the data points necessary to conduct a more appropriate thorough review. Cycle times were measured for the remaining patient encounters and broken into one of 5 corresponding groups: 0 to 30 minutes, 30 to 60 minutes, 60 to 90 minutes, 90 to 120 minutes, and greater than 120 minutes. Consideration was given to on-time patient arrivals, and those who were late were filtered out of the data. The average cycle time of all encounters was 99.24 minutes, with a range of 64 to 132.48 minutes. A comparison of all sites was also completed. The sites were interested in this data to determine how they may improve patient satisfaction, and the data is challenged by the types of patients each site tended to see, with some sites having a much more complicated patient population. In the end, one site is moving into a larger facility, which may positively affect this data related to workflow, and another site was found to have the most timely cycle times, which would conceivably allow for a more thorough review of their best practice processes to potentially impact other sites. Finally, more detailed flow mapping of a patient's experience from one step to another in the appointment process could be beneficial. The next project is titled Obstetrical Services and Patient-Provider Communication, a qualitative analysis of the communication between providers and patients at Matthew Walker Comprehensive Health Center. Student Dr. Lewis is an osteopathic student from the Philadelphia College of Osteopathic Medicine at their Georgia campus, and she completed her project at the Matthew Walker Comprehensive Health Center in both Nashville and Smyrna, Tennessee locations. Her project included a qualitative approach to the provider-patient communication, particularly focused around prenatal education. She interviewed 4 providers, including 2 from each location. The providers consisted of 3 physicians and 1 nurse practitioner. Providers described their patient demographics, which included patients from a variety of race and ethnicities, and they described the essential information that clinicians should communicate to expectant mothers. This included advice around the importance of increasing water intake, daily prenatal vitamins, healthy diet and oral health, and providers also emphasized the importance of taking a thorough past medical and pregnancy history, as well as the current state of fetal movement. Open and honest dialogue was stressed, as well as an educational program that was developed to better inform patients about these important issues. Finally, providers agreed in their communication that adverse social behaviors and poor eating habits were most commonly contributing to the infant mortality among their patients, and a prior history of miscarriage was one of the major warning signs. Student Dr. Lewis used the information she developed to start a manual that could be utilized as an educational resource for patients. The next project is titled Raising Decibels, Engaging Deaf and Hard of Hearing Patients. Student Dr. Kothi is a medical student at the Commonwealth Medical College in Pennsylvania, and she conducted her project with Adelante Healthcare in Phoenix, Arizona. Her project centered on the care of deaf patients, and she arranged for a deaf and hard of hearing sensitivity training by a deaf specialist with the Arizona Commission for the Deaf and Hard of Hearing that all providers could attend as part of their ongoing curriculum training. She also developed a list of American Sign Language courses in Maricopa County, where Adelante Healthcare is located, that could be utilized by the providers and staff. She also researched and helped facilitate a contract with a new American Sign Language interpreting company for the providers, and a review of current procedures in hiring a sign language interpreter found ways to improve the system to ensure deaf and hard of hearing patients were provided with appropriate interpreters. The comprehensive project provided a new approach to providing patient-centered care to deaf and hard of hearing patients. One interesting nuance of the project was the discovery of a potential technology improvement in this important issue. The use of video remote interpreting will be a service that is offered in the future, which can help ensure adequate coverage to improve patient-provider communication. The next project was titled Showing Up, an evaluation of no-show rates. And this was completed by Mr. Daryl Nowacki, who is a physician assistant student at Chatham University in Pennsylvania. His project was completed at Central Med Community Health Center in San Antonio, Texas. The project consisted of reviewing the issue of no-show rates at the clinics, which was found to be 30%. There were many opportunities to consider related to improving these rates, but Mr. Nowacki decided to focus on a few specific ones, including a new automated call system that had not been implemented until a few months prior to his arrival. This implementation was not without challenges, particularly related to patient comfort and technological issues, but it was considered to be the best option for Central Med given the enormous manpower related to personal calls of over 1,000 patients each day. Mr. Nowacki offered that a few changes to the process could help enhance the system and reduce the rate of no-shows. First, allowing patients to select the option of their preferred language at the time of their appointment could alleviate some of the challenges with the phone system and technology. Second, having the calls go out in the evening may allow a higher rate of successful connections with patients, as he determined that many of the patients in this clinic were working a first shift. Finally, he demonstrated in his project the cost-benefit ratio related to postal reminders, and he posited that this would be a more cost-effective approach for some patients. But he also suggested that text-based technology should be considered for younger patients who may be more receptive to that technology. The final project was titled Solutions in Treatment in Obesity Management and Prevention, an analysis of the efficacy. And this was completed by Ms. Michelle Lagua, who is a 2012 graduate of the Keck School of Medicine of the University of Southern California Primary Care Physician Assistant Program. She completed her project with Ultimed in Los Angeles, California. Her project focused on evaluating and emphasizing the importance of parental participation in a childhood obesity treatment plan. Her project emphasized the epidemic of childhood obesity, particularly in disadvantaged communities, which Ultimed serves in the greater Los Angeles area. The issue of childhood obesity is further complicated by decreased access to healthy food and green space for exercise, poor health literacy, and limited resources that prevent families from seeking low-cost food and exercise options. The project focused on the STOMP program, which provided families at the Boyle Heights Clinic in East Los Angeles with access to a 12-week medically supervised curriculum with a registered dietitian and a physical activity specialist. The program was provided to patients who had parental participation and parental accountability. Weekly educational classes are provided, along with 60-minute exercise sessions, and families undergo an additional 9 months of weekly follow-up, including visits to their medical provider. Successful participants receive a certificate of recognition with a graduation ceremony and supermarket gift cards. A total of 24 children and their families were enrolled in the STOMP program this past May based on BMI criteria for obesity. There was a correlation between obesity among children and their parents, which further emphasized the strong trends in the family unit. Of the 24 families, 7 were withdrawn and re-enrolled in an upcoming session. The remaining families had changes in their BMI in both parents and children, including a 1-point reduction in BMI in many of the age groups. The effectiveness of this program is promising, but more data is required to provide clarity in the potential outcomes and cost-benefit ratio of this type of intervention. I'd like to ask the scholars some discussion questions to consider as part of their reflection of this project and experience. First, I'd like to know what the main take-home lesson was that they learned in their project, perhaps that one thing that they think will stay with them for the remainder of their career. Second, I think it'd be helpful to understand some of the barriers that they experienced related to the project, and perhaps how they overcame those barriers. Third, I'd like to see how they might approach this project differently beyond just the barriers, but if they were given a second chance to do this project, what kind of things might they do the second time around that would be different from their first experience? And then finally, I'd like to understand a little bit how this experience influenced their thoughts about a career in primary care.